Welcome, guys. If you could give me a minute, I need to hide this so that we can continue. Now, in today's session, we'll be discussing about left-sided heart failure. We will define it, look at the causes, describe the morphology, especially of the lungs and of the heart, then look at the clinical features, and then we will compare left-sided heart failure and right-sided heart failure. Welcome all. My name is Otis Munyedi, and I'm the Dr. Let's start with the definition and pathogenesis. Now, left-sided heart failure is simply the inability of the left ventricle to pump blood into the systemic circulation. Left ventricle receives blood from the left atrium, which had received blood from the pulmonary veins, the oxygenated blood. Now, it has to pump that blood. Inability to do so, that's the left-sided heart failure. Now, it can be caused by an ischemia, hypertension, systemic hypertension, dilated cardiomyopathies, myocardial infarction, and restrictive cardiomyopathy, with amyloidosis being a form of restrictive cardiomyopathy. We also had another one which was known as the low flash endocardiomyopathies. Now, let's look at the morphology. Now, in the heart, some gross cardiac findings, the gross cardiac findings will depend on the underlying cause of the disease. Okay, it can be due to a myocardial infarction or a valvular deformity. Now, in a myocardial infarction, you might see such. This is a scar tissue. Okay, this is a scar tissue from a previous myocardial infarction, and this can lead to can cause chronic ischemic heart disease, or the progressive heart failure, okay, which is also known as the ischemic cardiomyopathy. Okay, now in general, the left ventricle is usually hypertrophied and dilated, except when there is mitral valve stenosis or restrictive cardiomyopathy. Okay, and this left ventricle dilation can lead to mitral valve insufficiency, hence mitral regurgitation, and you know the regurgitation will lead to left atrial dilation, and this can lead to atrial fibrillation. And the fibrillation, together with the dilation, will lead to stasis of blood within the atrial chamber. And stasis, remember from the Vicos triad, was one of the causes of formation of a thrombus. Now, the microscopic changes in the heart are non-specific, and they will be myocyte hypertrophy with interstitial fibrosis. Okay, then superimposed on this background may be other regions that contributed to the development of the heart failure, such as this scar tissue from a previous myocardial infarct. Now, let's look at the lung morphology. Now, due to the left ventricular failure, there will be a backward failure, and this will lead to rising pressures in the pulmonary circulation. And eventually, there will be a congestion and edema, as well as a pleural effusion. Why? Due to increased hydrostatic pressure within the venues. For pleural effusion, due to the venues of the visceral pleura. Okay, now the lungs are usually heavy and bulky, and microscopically you will see perivascular and interstitial transudation. Okay, transudation. Please note it is transudate, not exudate. Transudate. There's a difference between a transudate and an exudate. Now, there will be also alveolar septal edema and accumulation of edema fluid in the alveolar spaces. Now, when we have chronic heart failure, due to the increased hydrostatic pressure within the capillaries, they might burst. And this bursting might lead to the extravasation of the erythrocytes. And this extravasation of the erythrocytes within the lung parenchyma will lead to phagocytosis by the macrophages. And these macrophages, or the alveolar macrophages, or the dust cells, will break down the red blood cells and hemoglobin, and this will lead to the appearance of the hemosiderin-laden alveolar macrophages, which are also known as the heart failure cells. So heart failure cells are found in the lung, not in the heart. And the other name of heart failure cells is siderophages. Okay, and this, once you detect, and here they are, okay, these hemosiderin-laden macrophages, those are the heart failure cells. This is the normal lung parenchyma. You can see the simple squamous epithelium here. Okay, so once you see this, they are indicative of previous episodes of pulmonary edema. Now, let's look at the clinical features. Now, the most important symptom and the earliest one is dyspnea, which is shortness of breath, okay, on exertion, okay, and it is a significant symptom of left-sided heart failure. Cough is also common, and it is due to a consequence. It is due to fluid transudation into the alveolar spaces. Okay, now with progression of the heart failure, the left-sided heart failure, there be an orthopnea, and this is a dyspnea which is induced by recumbent position. So when the patient lies on the supine position, like when sleeping, you expect that the venous return from the extremities will increase. So with the diaphragm move upwards, okay? And these two factors will lead to increased preload into the right ventricle. And since the right ventricle in this case is not more, so there'd be more pumping into the already congested lungs. So the pulmonary congestion will even be exacerbated upon lying on a recumbent position. So they will develop a dyspnea on lying on the recumbent, lying on a recumbent position. So that is what orthopnea is. Now, and this orthopnea is usually relieved by sitting or standing. So the patient is usually advised to sleep in a semi-seated position. Otherwise, if they sleep on the supine position, they will have attacks of dyspnea during the night, what is known as paroxysmal nocturnal dyspnea. Okay, okay, and these occur as episodes of breathlessness, which awaken the patient, and they have extreme dyspnea, and those bordering the feelings of suffocation. So the patient will wake up, most wake up terrified, and they have that feeling as if they were suffocating. When you see that, I suspect left-sided heart failure. Now, other manifestation will be left ventricular hypertrophy, cardiomegaly, tachycardia, the third heart sound. Then, upon auscultation of the base of the lung, fine rails will be heard, and this is due to opening of the edematous alveoli, mitral regurgitation and systolic murmurs due to the outward displacement of papillary muscles due to the hypertrophy and the chamber dilation, then atrial fibrillation due to the dilation of the left atrium, and this will lead to reduction of end systolic volume and diastolic volume and the systolic volume. Why? Remember, in the cardiac cycle, we had in the ventricular filling phase, we have two phases, a passive phase and the active phase. Now, when we have atrial fibrillation, the active phase is lost, okay? And this will reduce the end diastolic volume and the systolic volume. And also, atrial fibrillation and that chamber dilation leads to stasis, hence a thrombus formation. Remember, from the Vicus triad, abnormal blood flow was one of the contributive factors for the formation of the thrombus. Also, due to renal hypoperfusion, remember the stroke volume has decreased, so the cardiac output has also decreased. There be activation of the renin, angiotensin, aldosterone system, and leading to salt and water retention. And due to salt and water retention, there be increased venous return, and this will now exacerbate the lung edema. Now, there'll be also a prerenal azotemia. Azotemia is elevated levels of blood urea nitrogen, and due to, it can be either due to, there can be a problem, a prerenal problem, so a prerenal due to, say, renal hypoperfusion, so decreased TFR. It can be also a renal azotemia or a postrenal azotemia. So this In this particular case, a prerenal azotemia will be there. There will be also ischemic hypoxic encephalopathy due to brain hypoperfusion, and this will present as irritability, diminished cognition, restlessness, and a coma can result. Now, the mainstay of treatment is ACE inhibitors, and ACE inhibitors, you know, they limit, they oppose the aldosterone-mediated salt and water retention, but also they limit cardiomyocyte hypertrophy and remodeling. Okay, and the mechanism by which ACE inhibitors do that is still uncertain. So I have a table showing you the differences between left-sided and right-sided heart failure. I want you to notice that. Please remember that left-sided heart failure is the main cause of right-sided heart failure. Okay, and also please remember the nutmeg river. Okay, and the symptoms, the presentation of right-sided heart failure is mainly due to venous congestion, but the lungs are spared in this case. But in the left side, it is mainly due to pulmonary congestion, with dyspnea being the earliest and the most significant clinical presentation. And we also remember heart failure cells in the lungs, not in the heart. Okay, and the activation of the RAS will exacerbate the pulmonary edema. Also remember orthopnea, which is dyspnea upon recumbency. Okay, when the patient rises on a supine position. And remember cardiac cirrhosis, which was the fibrosis of the centrilobular areas in the chronic right-sided heart failure. Okay, and the peripheral pitting edemas. Okay, now I think we are done with that. Thank you for your time and attention, and follow for more of med content. Thank you.